Hi, I'm Tyson Franklin, and welcome to this week's episode of the Podiatry Legends podcast. With me today is Dr. Timothy Shea. Now, he has been on before. He was on episode 202, and I titled it A Podiatry History Lesson. Now, the reason I titled it that was because he has been in the profession for 50 years, and at 76 years of age, he is still as pumped up today as he was at the first day he graduated. And he went through the California College of Podiatric Medicine, and he learned from the legends of Merton, Root, Orion, and Weed. And I've got him back on because when we spoke last time, we touched on a subject just very, very briefly about foot manipulation. So today we're going to talk about foot manipulation therapy in pediatric medicine. So, Tim, how are you doing today?
I'm doing great. Thanks, Tyson. Thanks for having me back on. I really appreciate it.
And I was actually very happy with my introduction then.
That's
Sometimes,
lovely.
sometimes I totally butcher it, and I listen back to it later when I do the edit, and I go, "Oh, it's a terrible introduction." But I felt really good about that one.
It
It must be
great.
might be my new microphone.
Oh, that's it. All right.
I think it's the new microphone I have. I've had the same microphone for about 4 years, and I've just switched.
Yeah.
So let's get on to today's topic. Let's just dive straight into it. When I had you on last time, I think I mentioned to you that I first came across the word foot manipulation. I think it was about 1986. I read an article and I said to my lecturer at the time, Alan Crawford, who was the head of the department, "Can I try this on a patient?" And he gave me a bit of an odd look. Knock yourself out. Why not? So I did, and it worked really well. It was on a patient's cuboid. So I messed around with it off and on through my whole career doing that. But you've been doing this well before 1986.
Right. Yeah. I was introduced in 1973 to one of the writers of the books. The name Dr. John Mennell, Mennell. He MD. He was a English trained orthopedist, and he worked through the Veterans Administration Hospital out here in the Contra Costa County area, which was affiliated with our school at the time. We did rotations through that. And I was walking through the hospital one day, and I noticed out of the corner of my eye, somebody was doing something to feet, and they were kind of pulling and tugging and all kinds of stuff. And it kind of caught my attention. And so I went in, and it was in the physical therapy department.
Yeah.
And there was a fellow, and he was doing this. And I said, "What are you doing?" And he says, "Well, I'm doing some foot manipulation." I said, "Wow." I said, "That's interesting." I said, "Are you a chiropractor?" And he says, "No, I'm an orthopedist." And I almost fell over because back in those days, orthopedists wouldn't even talk to podiatrists, much less let you in the room with them politically.
Yeah.
And I was fascinated with his concept. And I said, "Well, I'm kind of familiar with the term, but I've never seen it done." He said, "Well, we use it all the time here in physical therapy." And I said, "Well, how much?" He said, "Well, if we see 100 patients, we'll do about 50. I thought, 50? Wow. And I said, "Feet?" He said, "Feet." He says, "It's by far the most commonly used. I mean, it's the most common need is in people who have foot problems. They benefit from this modality." And I was completely flabbergasted by this. And I said, "Well, gee, can I look into this some more?" And he said, "Certainly." And he showed me his book, and I'll show you here. It's his, I know he can't see things, but that's his book by John Mennell.
Joint Pain.
Yeah, Joint Pain by John Mennell. And he wrote a number of these books that were like compendiums.
Yeah. And you're saying this is going back to 1973 was the first time
73
you came across this, yeah.
73, yeah. And so I went back to our school, which is the California College, and I did not get a good reception. It was like, "What are you talking about?" And I said, "Well, this thing called manipulation. Can I either learn about it?" And they were kind of like, "No, you can't. You can talk to this doctor, but you can't teach it. You can't do it back here at school." So I had to kind of do it on my own. It was like on the job training. So I contacted Dr. Mennell, and I said, "Hey, if I have some free time, can I come over and spend some time with you?" And he was very lovely man, very, very outgoing, and sure, come on over. And he then, as I got to know him a little bit, he expressed that he had tried to teach at the school as well.
Yeah.
and kind of received the same response. So he backed off and just
What was there when they said no at the beginning? Were they looking at this as voodoo? It doesn't work. Was that their intention? Because it wasn't backed up by any research. Was that part of their problem?
I think the challenge at that time was that there was still politics involved in the conversion from chiropody to podiatric medicine.
Yeah.
And they saw this as being chiropractic, and they didn't want to go. They didn't want to mix those two words together. However you want to.
So I think they were taking a step backwards instead of going forwards.
Yeah, and so it kind of, and by the way, when I was in training, I was in training to become a teacher. That's what I was planning to do. I was planning to teach at the medical school, and that was going to be my career. I was going to be a teacher. And so it kind of bothered me a little bit that they wouldn't allow me to learn stuff to teach at the school. And so I did have to take a little step back because I was going into residency, and that was highly competitive and that kind of stuff. And so I go visit Dr. Manel regularly, as much as I could on the weekends or on days off. And then during my residency, the same thing. I had to kind of squeeze it in here and there, and I got to be a little bit better at it. And then when I finished my surgical residency, I actually spent 6 months with him almost daily, working with him in his clinic in the Veterans Administration. And so I would introduce it into my classes in school, kind of as a physical therapy modality. I didn't call it chiropractic, and I didn't even call it osteopathic. I just said this is a modality that you can use to help treat people with foot problems. And the terminology that Dr. Manel used, which I liked a lot, is foot dysfunction. He would describe what are called joint dysfunction conditions, which could occur from a whole bunch of conditions, from injuries to the thing that kind of would surprise everybody would say, you can get this from having a wart on the bottom of your foot. And people go, wart? Like, well, yeah, if the wart hurts and you start changing the way you walk, it's going to eventually throw the function of your foot off, and you're going to have other problems, which we all know about, which can lead to ankle, leg, up the leg to the low back and the sciatic area.
Yeah.
So he commonly would show how these things would relate. And then from that, he would then talk. So the one hand was diagnostic, and on the other hand was therapeutic. And the diagnostic approach was learning what he called joint play, P-L-A-Y. And joint play is what exists as a natural level of all joints and pseudo joints. So in the foot, we have the joints of the metatarsal, phalangeal, and all the various mid-tarsal, root foot joints. These are all known anatomical joints.
Yeah.
But there's also pseudo joints. So for example, between the metatarsal heads, you have a bone, and a synovial fluid, and then you have some soft tissue. Well, that's a joint as well, as far as function goes. And so many things that we commonly referred to as neuroma symptoms really weren't neuromas at all. They were dysfunction of the intermetatarsal joint, if you want to call it that. And this is how he kind of taught you to get used to utilizing the technique, first of all, for diagnostic purposes. And I always explain this to students and people that are interested, that the very first thing you want to learn is how do you utilize the techniques to evaluate a foot. So as I mentioned, I just lectured last week. I'm going to show you a little picture here. I just mentioned last week, I gave a lecture at the Anaheim Convention, which is the California Podiatric Medical Association. And in the United States, there's a famous football coach whose name is Vince Lombardi.
Oh, I've heard of Vince.
Yeah, and Vince Lombardi was a famous football coach of the Green Bay Packers back in the day when they were just tremendous. But they got into a point where they got too full of themselves, and they were making a lot of mistakes. And so one day he brought everybody onto the field, made them take off all their equipment and everything, and he brought out a football. And he said, "Gentlemen, this is a football. We're getting back to basics." So I brought this out and I said, "Gentlemen and ladies, this is a foot, okay? And the most basic concept of manipulation applies to this guy, this part right here, the most basic thing, the little tiny things. And I wanted to get across that when we're talking about this concept is don't get hung up on the therapeutic technique per se. Like you said, you did one where the cuboid adjustment and that kind of stuff. Those are all great therapeutic, but the basis of everything is to learn how to evaluate literally almost every joint of the foot individually. And to be able to do that, what you have to learn is, first of all, learn what is that motion. And the name is called joint play. And it's the ability, the way that Dr. Manel explained, it's the ability to begin motion. So it's equivalent to a hinge on a door. There is a relationship between the hinges that allows them to begin to move. And that's called the play within the hinge. And if the hinge loses its play, it squeaks. It makes a squeaking noise. And you usually have to go lubricate it somehow.
Yeah.
Well, in the body, when your joint squeaks, it hurts. And this is called the Ruffini apparatuses of the joint capsule, which then hurts. Well, what does it do? Well, it goes into spasm. And when it goes into spasm, the intrinsic muscles, extrinsic, etc., they begin to backtrack to stop range of motion. And so you lose range of motion, you lose joint play, you then have to compensate at some other joint, and then it just kind of goes right on up the foot and up the leg.
So how long, you said you worked with him for about 6 months.
Yes.
Pretty solid.
Yes.
When you had finished doing that 6 months, was it every day you were catching up with him, or was it once a week? What was the training like that you went through?
So what I went through with him is I had about 2 months of free time between the end of my residency and the beginning of my teaching career. And I spent almost every working day with him in the clinic at the Veteran Administration Hospital.
Okay.
And I worked with him every day. So the first thing I had to learn was all the various joint play movements of all the various joints. Again, he taught them to me, but it's in textbooks and stuff like that. It's really nothing, there's nothing superstitious about it. It's just a real thing.
Yeah.
And then he allowed me to start working on patients, the VA patients who came in with different ailments around their foot. And little by little, I first had to teach them that I knew all the play motions that were available. And that takes time. That takes about a month or so to show that you know. And by the way, the way he did it was he would say, okay, I want you to learn the subtalar joint play, or I want you to learn the mid-tarsal joint play, or the metatarsal phalangeal joint play, of which there's 4. And then he would say, okay, now do it on me, do it to him. And that's how he'd say, okay, well, no, you don't have it yet. You're not feeling it right. You're not moving it right. And then I'd have to go practice either on a patient or my family, which is one of the things I recommend to people. If you're going to start doing this, do it on your family first.
Yeah.
Say, practice on your family. And then when I got it point where he said, yes, that's exactly the movement we want, that's what you want to reproduce, then he allowed me to start learning the techniques of applying manipulation to the joints. And there's different ones for different maneuvers. And then we got into the therapeutic. So 2 solid months of that. And then when I started teaching, I made an arrangement with him that I would come in about every weekend or every other weekend if I couldn't squeeze every weekend in for a whole year.
Okay.
And he was lovely enough to come back and work with me on the weekends. And so by the end of the year, I was competent, he said. I was competent, not great, but competent to not only use it diagnostically, which I really think it's much more helpful for everybody. Everyone can use this, to therapeutic, which requires a little bit more, technique and training and time to learn how to do the techniques as well. So by the end of the year, I was competent enough in my mind to both treat patients and to be able to teach it at school. And by the time that year rolled around, I was beginning to be a little bit more, I started off as a assistant professor in the medicine department. And then I migrated, eventually I became the director of the podiatric medicine department, the dean of the podiatric medicine department.
Yeah.
And then I became the director of clinics. I was the big kahuna of the clinics. And once I was in charge, I just put it right into the clinic. I started teaching it in the clinic. I taught it in classes. I gave lectures, and so now I could kind of get the ball rolling. I actually brought Dr. Manel in, and he lectured. And then eventually I met up, and we'll talk in a second I met up with Rue Ticker, who is a podiatrist who utilized manipulation technique because he was trained by Dr. John Hiss. And Dr. Hiss is the fellow, and here's his book, Dr. Hiss, Foot Disorders. This is actually a 1937 edition of his book. And this is my Bible here. And in it, he shows his techniques, and he describes how he versus, and this is actually, this is a biomechanics book. This is a biomechanics book. He talks about biomechanics completely in the book. It's called Functional Foot Disorders.
Yeah.
And you just take that terminology and say, foot biomechanics, and you got the same thing, different terminology, same concept.
What was the time frame from 1973 when you first came across it through to you then being able to actually teach it to the students without anyone saying anything to you about it?
Right. It took till 1976. So it took me
3 years.
Yeah. And then when I was clinic director, I had no more. Who's going to tell the boss what to do?
Well, no, I'm picturing you now as a big kahuna, because I've seen the big kahuna in Hawaii. So I'm picturing you walking with your surfboard and the lei around your neck, just going, I am the big kahuna. Don't argue with me. So I take it that when you first started teaching the students, they loved it. I would say they jumped on board fairly quickly and said, we really like this. How did the rest of the profession react when you were teaching them this?
They weren't happy. They thought I was going backwards.
Yeah.
And the reason was pretty straightforward. I mean, in hindsight, we can see what the plan was, and that is they were moving away from the technical component of podiatric medicine into the medical surgical component of podiatric medicine. And they really wanted to emphasize the hospital concept, the medical concept, the surgical concept, really primarily the surgical concept. And they felt that they didn't get how the two work together. They thought one was instead of the other.
Yeah.
And my fortune was that since I met Dr. Manel, who was an orthopedist, he showed me how the two work together, and they can help each other either with surgery, without surgery, before surgery, after surgery, or after whatever, a bunch of injuries or whatever, how it mixed in with everything else we were being taught. But the profession did not like it in that respect. However, I give people, they respected me for doing it.
Yeah.
It's kind of like, well, you can do it, and if you can teach it and people can learn it, that's fine. But that's not our primary focus at this point in time. We're going in a different direction, which was hospital-based medical surgical care.
Okay, so as the students were coming through though, and they were learning this, and this is just becoming part of their treatment, once that first group that say graduated, that left the podiatry school and went out to do the residency, were you getting much feedback from them coming back that they were being told, hey, put that voodoo away, we're not ready for this yet? Did anything like that occur?
Of course, yeah. I would say if a graduating class was 45 to 50, within 5 years, I'd hear back from about 5 who said, I'm using it and I enjoy it. The rest would say, I'm not using it, I don't get it, I'm being told not to use it. Especially if they went to residencies like me, they were told not to discuss it or to talk about it. They're actually getting pushback, and some stuck with it and still do today. I've met people at the recent meeting, a fellow who's in his 80s who's still utilizing it in his practice.
All right, that's good.
Yeah, it's great, but it wasn't accepted back then. But part of that was because as a whole, so-called the concept of biomechanics was actually new. Was new, in not just the profession, but generally across the board. And the idea of sports medicine and rehabilitation medicine, this is all new. And trying to integrate all these different elements was hard. It was hard, And so, and the concept of manipulated techniques, and what I try to get across to everybody is, it's not voodoo, as you mentioned. It's not that. It's a real thing.
Yeah.
One guy said, I don't believe in it. I said, it's not a religion. Okay. You don't have to go to church over this thing. You just have to know what the basics are. And the second half of it is, if you're going to do it, like almost anything in medicine, you really got to be good at it. And that means you have to practice it. And, if you're doing, for example, in my practice, let's say out of 30, 35 patients, I'll do it about 10 or 15 patients will get some form of manipulative treatment as part of their treatment program. And that's a lot every day, over 4 years.
Yeah, I was going to ask you what percentage of your patients that come and see you now, are you still doing? And what would you class the difference between foot mobilization and foot manipulation?
Right. So technically they're in the same category. Mobilization is, again, movement of joints through the range of play and then accentuating to the range of motion. Joint manipulation is taking a joint through its range of play with velocity under control.
Yeah.
And so the only people that can do manipulation are physicians and podiatrists and chiropractors in the United States, osteopaths and chiropractors. Physical therapists can do mobilization, and they do a very good job. And I do know some do manipulation, but legally speaking, only a physician degree will allow you to do manipulation. But you can still get very good results with mobilization. But if something's really stuck, you have to really get in there and really open that thing up. If you can do it with some velocity, it makes a big difference. It makes a big difference.
Okay. When would you say the profession in America started taking on board that we know this works, we know it's beneficial for our patients, and you stopped having people using the word voodoo or just, I'm not really into that sort of thing? When would you say it started to become a bit more mainstream?
I'd say about 15 years ago, right when sports medicine became a thing. Okay. So not just sports medicine and podiatry, but sports medicine across the board, orthopedics, general physiotherapy, rehabilitation. When that started to really become a subspecialty of medicine and all the medical fields, then manipulation came out because it had to come out. You have, if you're going to treat these kinds of folks who are athletes, whether they're high-end athletes or weekend athletes or whatever they do, or if they're athletic to stay healthy, and something happens to them where they lose the ability to continue with that activity, the consequences are tremendous, because now they cut back on their activity level. Now they become frustrated. Now they get fatter. They start gaining weight. And they get depressed. And, it's a whole cycle of things that happen. And the challenge is, if you're fortunate enough to have someone like that come into your practice, and you do a few things that we do anyway, tape, strap, orthotics, shoes, modifications, and that helps them, which it usually does.
Yeah.
That's great. But if they have that little extra, 10 to 15%, they're not quite where they want to be. That's usually because something functional is not working right, and they're still compensating. And so when you can add that last little bit of therapy to restore function, and that's the whole purpose of this thing, is just to restore normal anatomical function, then that's that last step that gets them back to the activity level that they wanted to be at, whatever it is. And then they really appreciate it. And, for something which, and the other thing about it is, here's your tools. This is it.
Yeah, you don't need much else other than your hands.
You don't need just your hands. Okay. And that's amazing to be able to provide that for someone. And if they benefit from it, well, who are they going to go see to get it? Well, they have to come back to you.
Yeah.
You can't reproduce these in other people, at least not yet. And so that part of it, that gets it, okay, that's someplace I can go to get help. And very commonly, I'll have folks who athletic of some kind, They get injured, they get treated. We do our program, and they get back to their athletics. And 6 months, a year and a half later, they get injured again, and they come back in, and we're able to provide that kind. And then that builds on each other. And then finally, what happens is, as I did, you go out and talk to people. You actually go talk to chiropractors. And you go talk to osteopaths, and you go talk to other podiatrists. And what they'll do is, if someone's interested in it, they'll look into it themselves. But the vast majority will just say, you know what? I know someone who does this to the feet, you go over there, I mean, I'm not going to do anything else. You just go see that person over there. And then they come in and I do my thing. And it's about 4 to 6 treatments for the average person. And then they go back to where they came from, so there's no fighting over this kind of stuff.
Yeah. Well, so just to get back one step, when I asked about it becoming a bit more mainstream and being accepted, we'd say it's sort of around the same time as well, because you said, like in America, everything was progressing towards surgery and that side of podiatry. But then all of a sudden, I noticed there was a shift where a group of podiatrists, it was sort of like, it's okay if you don't want to do surgery.
Completely.
And there seemed to be this movement over the last, say, 15 years of some podiatrists, but they do their training, do the residency. And once they finish, they've already made the decision. I don't really want to do surgery.
Oh, and also I don't want to go to the hospital and spend 3 hours waiting around to do surgery. And there's another element of it, which is financial. And that is every time you do anything in the hospital, they take money away from what they pay you for. So if you can do something in your office on an outpatient basis, A, you're in control because it's and B, financially, it'll be more, I'm not going to say it's better. It's just that it's appropriate. It's what you should be reimbursed for because it's in your bailiwick and you're in control. And so I'm of that group, by the way. And just at this point in time, I do very little hospital-based procedures. I'll be happy. I share it with my very young colleagues as they come out of the residencies if they want to do it. I'm very happy for them to do it. Yeah. I know they will eventually come around to seeing it differently, as everybody does. But yeah, that's correct. About 15 years ago, people started to I pull back, and now they really, really, really want to know how to do this technique and how to utilize it in patient care. And that's actually increased it each year. And at this last seminar that I gave down in Anaheim, there's about 400 people there to listen to it. Again, get caught up on it. And it was great to see that many people were interested in getting back into the, I don't want to call it old school. It's been around a long time.
Yeah. Yeah. And I've noticed the shift over in the States because I've been getting this magazine, Podiatry Management, for like over 30 years. And the recent one just turned up on my desk. It's got Doug Ritchie actually on the front cover as well. I think it's the June-July issue. And yeah, and I've noticed as I've been reading through that, about 15 years ago, I noticed that slight shift where certain things were getting mentioned in the magazine that weren't prior to that. And now it seems to be okay. If you don't want to do surgery, you don't have to do surgery.
Yeah, no, it's perfectly fine. And especially as with almost anything being successful, what do they say? Be the first, the best, or the only. Yeah. If in your community, you're one of those 3 things, or if you're all 3 or even better, it makes a difference because it crosses the barriers, the political barriers of medicine that, an orthopedist will have no trouble sending you foot for adjustment techniques because A, they don't do it, and B, they know someone does do it, and they're just as happy to send them to you as anybody else. And even a chiropractor who may have learned it in school, because they do teach it now in school. They never taught it before. They do teach it now. They may know how to do it, but it's like anything else. If you don't do it all the time, how good are you? And that's really something.
Yeah. Well, it's like anything. You've got to just keep practicing. I think all your skills, any skill that you don't keep practicing, you're going to lose it. Doesn't mean you've lost the skill completely, but just you have to then almost retrain yourself to get good again.
Right. And like we were talking about, it's something you do on a daily basis. You're going to be more competent at. And the other part of it is not just the therapeutic, because the therapy part of it, the treatment part, I learned that from another doctor, Dr. Ticker, when I went to work with him after I was done teaching. And he taught me all the other office-based techniques of how to utilize it, because he'd been trained by the guru is named Dr. John Hiss, Hiss, MD osteopath in Los Angeles back in the late 30s, early 40s, who had these clinics that were just dedicated to doing foot joint manipulation techniques.
Yeah.
And they saw hundreds of patients a day. And so then I took my academic learning and then I put it into practice. And that was about 1983 when I went out and started working in private practice.
Okay. I just got a question about this joint play again.
Yeah.
Is if, say, like, because I get a lot of students that listen to this podcast as well, and they may be, they're at university at the moment, and they're getting told about joint range of motion. So how would you describe the difference between joint range of motion and joint play?
Right. So if we think about the concept anatomically and functionally, joint range of motion is something which you can actually measure. That is, there's enough motion available at a joint that you can take a goniometer or some device and measure how much, let's say at the MP joint, how much dorsiflexion and how much plantar flexion is available at that joint.
Yeah.
And that's the, I'll call the max version or the macro anatomical. But what joint play is inside the joint, because of the relationship between the synovial fluid and the cartilage, there's 4 play motions. One is called extension, which just literally means pulling it out. Others called glide, which is slide it up and down.
Yep.
Then side to side tilt and rotation. So there's 4 play motions. That how do you tell the difference? That's what you have to learn to do with your hands. That can only be, it's such a small degree of movement that you have to learn by feeling it in your fingertips. And so there's where the anatomical part comes in. So this is micro biomechanics, which is very basic stuff. And every single joint in the foot and body, for that matter, has some type of play. It's all have some play motion, which can be felt individually. And you just have to learn what those are. Someone has to show you it, and then you have to start doing it. And there's certain techniques, all of which are relatively easy to learn, but it's all in your hands. And so it's not range of motion, which you need, like you take an instrument or look on an x-ray or a fluoroscopy or something like that to see what it is. You don't need that because it's all in your hands. And your hands and your brain become one instrument together. And as you do it over time, you literally feel which one of the different amounts of play that should be available is still there. And then there's a couple of techniques which are a little bit larger. One of them, which people, and you might have seen it yourself, it's called the cuboid lift test. And when we talk about the cuboid syndrome, there's a little mechanical slide motion between the cuboid and the calcaneus. And if you put your hand right underneath it and you kind of lift it up a little bit, if that joint is locked up, you can move a person right out of the chair. I mean, they'll just head right on up and you're barely lifting up on the joint at all, and they will just leave the room. That's where all the problem is. So you get to the point where little range of motion, little play motion, bigger play motion, and it leads you step by step in the area. And then that play motion is what then allows you to do range of motion. Yeah. So play comes first, range of motion comes second. And you can't get you can't get range without the play. And sometimes people get a little worried because the range of motion is decreased or it's not movable and they don't know why. And it's because the joint has lost play. And part of the reason joints lose play is there could be inflammation, there can be infection, there can be tumor, and there can be injury. Yeah. And so there's reasons for that. And of course you have to run that down to see what's causing it.
So what I like about all this is when you said, and this is where the practice comes in. It's like having the first MPJ and doing those 4 movements. Do it on 2 people. Okay. You learn a little bit. Do it on 200 people. you're going to learn a little bit more. So really, anyone who's listening to this who wants to understand joint play better pretty much needs to do it on every single patient, even if they're not even telling them what they're doing. It's just part of their exam just to get that feel themselves. So then they can start telling different, oh my God, that patient was completely different to the one before, which is different to, say, my partner at home. And it's just keep doing it.
Yeah, no, that's such a critical point that you make, that you can do it while you're doing your regular physical examination of the patient and just include that in it. And it doesn't even have to be something you report, it's just you do it. And as you say, as you feel the differential over time, you'll start to be able to pick it up. And it's just something, when I see all my patients, even if they're not in for a joint problem, like an ingrown toenail, I'll still go ahead and take the foot through a couple of range of play motions just to see how it feels. And if it's nice and flexible, we're good. If it's stiff, well, I say you might have to address that later on, So, but the other thing, by the way, the thing that I tell the doctors is, look, if you want to be a surgeon, or you want to be a biomechanics, or you want to be in sports medicine, even if you want to do palliative care, let's just say if you do these techniques on every patient that comes in, you'll become better at all of those other things, one way or the other. And you may pick up other stuff, or you will pick up other conditions that the patient didn't complain to you about at that point in time until you examine them. And they go, yeah, that hurts. Yeah, well, that hurt. How often? Well, that hurts me every day. Oh, well, maybe we should talk about that. I mean, your decision. But yeah, if you do it all the time, it becomes a natural thing. And of course, now with the internet and YouTube and all this kind of stuff, people are actually looking for specialists who provide joint manipulation, or they've heard the term cuboid syndrome, or they've heard chronic ankle syndrome, which, by the way, is a direct result of cuboid subluxation and ankle sprains. And whether or they've had surgery, been in a cast for a long time, and their foot just doesn't feel right. They're familiar with these terms, and they look for people who do that.
What I like about what you said then too, this is turning routine, like you can turn routine foot care into something that's more interesting. And I know there's podiatrists in Australia where they might be working in clinics where they're just doing general routine foot care, and they find it really boring. Yet I always say you can turn any consultation into an interesting consultation if you're prepared to just put in the extra effort. And that's all this is just putting in the extra effort and learning the skill.
Oh, totally. And that's an ongoing thing that you can do. When I first started out in private practice, commonly at the hospital, the referral would be, we need you to come to the hospital and cut someone's toenails. That was the referral.
Yeah.
And I, well, that's interesting. I said, do you ever call a surgeon and say, I need you to come in and cut out someone's gallbladder? Do you say, I need a vascular referral? Or they, oh, okay, well, then you need a podiatric referral. Oh, is that what we need? Yes, you need a podiatric referral. And then I did my podiatric referral. Now, at the end of the process, if what I did was technically some palliative care, that was okay. My consult was a podiatric consult. Yeah. And what happened was, over time, people say, oh, you do that too? And you do that other thing? And you do that other thing? Yeah, we do all that. And now, of course, now we only get hospital-based. There's just podiatry referrals, podiatry consultation. And it's for everything. It's for everything, anything with the foot. And it's the same in your office. Like you said, I have colleagues around here who express the fact that, quote unquote, all they do is palliative care. And I say, was that all you want to do? Well, no, I like to do some other stuff. Well, do it. I mean, what the patients in your office, they're in your chair, they're your patient. You provide the care that you think is the best care that they deserve, not necessarily what you want to do, but what do they deserve? And 9 times out of 10, they will come back and they'll say, oh, golly, I didn't realize these other things. And this just happens to be one modality that I think fits very easily, because you got your hands on the person anyway. I mean, you're there, you're
already there.
You're already there.
What I think is, I remember one of the first patients that actually said to me, checking the pulses of their feet. They said, what are you doing? some checking the pulses of your feet. Do we have pulses in our feet?
Yeah.
And what it was the first, and this was like probably my first year I graduated. It could be even been when I was a student when the patient actually asked me that. But all of a sudden it made me realize how interesting is some of the stuff that we do that patients don't realize, that we just do things without knowing what we're even doing. We're checking pulses. And we're not saying to the patient, I'm about to check your pulse. I'm doing it here and I'm doing it here. And then talking about why we're doing it. And all of a sudden it turns something that could be boring into an interesting conversation with the patient, which then can lead on to another conversation or other problems that they may have had. And next thing you're getting referrals from them for other family members.
Oh, absolutely. It's an incredibly, it's a great practice tool, but it's just the way you should practice anyway. I mean, that's what you're trained to be, is you're trained to be the foot specialist. And that's what we're looking for. We're looking for the best trained foot specialists, and don't cut yourself short by not taking advantage of something, and especially something which is non-invasive, doesn't involve sticking people or cutting people or anything. It's all, hands-on and practical. And as you say, the referrals are amazing that come out of this and again, also over the different age grade, from children to adults to older adults to athletes to, it increases your range of what you can provide and who you see in your practice as a specialist. And so that allows you then to grow and expand. And, we all get to a certain level of academic teaching. And then from that point on, it's experience. And that experience level is where you're in charge. As I mentioned to our students, I say, what you get from podiatric medical school? You get a ticket. All right. It's called your degree. All right.
Yeah.
That's what you get. And with that ticket, if you have the ticket, you're allowed to do things that would be called assault and battery on people if you didn't have the ticket. Okay. So since you have the ticket,
that's a great way of looking at it. Yeah.
You now can do it, and it's considered acceptable. But what you do with that ticket is totally up to you. And how far you want to take it and how good you want to become or how broad you want to be, this is up to you, and you need to do that.
That's true.
But that's such an important thing, to make sure that they understand that this is the beginning, not the end. It's the beginning of your career. And that's why in some respects, I'd like us to get away from calling things podiatry or podiatric school, because it's really not school. It's really education. It's training.
Yeah.
But it's just, that's the term. I know. I don't want to get too picky.
No, it reminds me, my brother's a dentist, and so many years later, he went and got a law degree because he was thinking about switching professions at one stage and becoming a lawyer, specializing in dentistry. And after he did his law degree, I said, so what's it like to be a lawyer? He goes, technically, yes. Okay, I have a law degree. He said, but I'm really just a glorified librarian.
Oh,
he said, what I've learned, he said, what I've learned doing my law degree is how big law is. And if you really want to be good at it, you need to specialize. And he said, there's just so much to know. He said, there's so much to know. And then it's really up to you what parts interest you and then where you want to take it from there. So what you're saying there about podiatry is very similar, is we get a piece of paper that says, yep, you're a podiatrist. You can do things on people that normally you go to jail for if you did that out in the real world.
Exactly. Yeah, right.
So, but now it's up to you. Where do you want to take your career? So if you were right into foot manipulation, you could go down that path. If you were into orthotics, you could just go down that path. If you just wanted to do nail surgery and be the best nail surgeon on the planet, you could just go down that path and leave everything else behind.
Right. And you'll be very satisfied, and you'll have a decent career, and you'll make a decent living.
Yeah.
And those are kind of the things. The beauty of our profession is that you can pick and choose and spend as much time as you want to, and you can still have a family life, and you can have a personal life, and you can live, be very happy. The term we hear nowadays is physician burnout. Podiatrists don't get burned out that much because we're not forced to do a lot of stuff that some physicians are forced to do. And you can choose, how much you want to spend on each one of these areas. And we have this open-ended field that we can go into almost any area we want to go into.
Yeah.
And so I give them, I say, you chose wisely. is what I say. You chose wisely, and now you need to continue your journey along those paths, and don't be held back by anything. And and then this is old man stuff talking here, and that is, when I was, starting out, people would even ask me, are you a real doctor? We call it the RD syndrome,
Yeah.
and I get very angry. I get really angry, and I really come down hard on someone who asks me that question. I don't hear that. I don't hear that anymore. It's not part of the lexicon. So that tells me over the years, our profession has moved us from that, whatever that thought was, to we're just accepted as physicians as anybody else. But that was a lot of people doing a lot of work over a long period of time, and it's still going on. We're not done.
No, I think the profession's got a long way to go. So I just want to remind people too, if you're listening to this just on the podcast, I recommend go to my YouTube channel, just look for Tyson E. Franklin. And because the video will be uploaded, so some of those parts where Tim was actually moving the foot and showing what he was doing with the foot skeleton, you might want to watch the video. If you're watching this already on YouTube, then you don't need to worry about that part I just said, because you're already here, which is fantastic. So Tim, I want to thank you for coming back on here. Do you have a final point or anything you want to say before we wrap up?
Well, my final point is that this technique, manipulative technique, I think is very effective. I think it really applies to all podiatrists in all fields. I recommend that you learn more about it, get good at it, and practice it, and do it, and use it. And if you need anything, you can always get in touch with me, or as Tyson was saying, watch on YouTube. I'm going to try and make some. It's kind of hard to watch it without putting your hands on, or go to a seminar where someone's giving it. Whereas, like in Los Angeles next year, we're going to be doing workshops on it. If you can get your hands on it, that's going to make it a lot better for you. But certainly utilize these techniques and enjoy it, and it'll be very satisfying for you.
So what's the best way if someone wants to get in contact with you? What's the best way of doing it? Because I know you still work at California Integrated Foot Care.
Right. That's the best way to get.
That's the best way. Well, I'll put a link to your business in the show notes so people can find it that way. I'll also put a link to the YouTube video if people are watching the video, and now they can go down and have a look at the show notes as well. And when you do run these different courses in the future, just let me know, give me the details, and I'll just pass it around to different places as well.
Great. And you can always invite me to Australia.
Now there is another plan. So that would be a good idea as well. So Tim, I want to thank you for coming on the Podiatry Legends podcast again. It has been fun. And I think we'll get you back on to talk about something else, because I really enjoy our conversations.
Well, thank you, Tyson. I thoroughly enjoy this.
Okay, thank you.